Yeah, I'll figure it out. All right. All right. Sorry, everyone. We're getting started just a couple minutes late here. A little bit of chaos in our lives.
Big chaos. Big
Yeah.
chaos.
I'm not Mike Voigt. I'm Ashley Campbell. However, Mike Voigt is hiding in my home because he has no power. For those who don't know, we reside in Nashville, Tennessee, which still has about 25% of our city without any sort of power. So it's been a little chaotic getting going. But thank you for joining us for the very first edition of Journal Club of 2026. Have a little bit of stuff going on. We're going to do a little change up of order tonight. I'm going to do the normal pleasantries here and go through kind of my spiel. And then we're going to flip things around and start with our case in point tonight, just because Dr. Provencher has a little delay in surgery. So we're not quite sure his ETA right now, but obviously priority is his patient care. So we're going to do what we can here. So I'll just go ahead and start sharing my screen per usual. And you guys see that okay? We good?
Yep.
Okay.
Yep.
All right, cool. All right. So all the pleasantries. Again, as always, we want to thank all of our sponsors, our title sponsors, ATI and IMISCA. Like I said, we're going to flip things around and start with our case in point series tonight, which is sponsored by ATI and IMISCA. Our founding sponsors, Innovus Woodway and Hyperace, our platinum sponsor, Elevation, and our gold sponsors, as well as all of our partners that help make IJSPT possible, as well as this journal club. Don't forget, these are posted on podcast format as well as YouTube after the episodes are done, usually within about 24 to 48 hours if you want to re-listen or share them. Reminders that your CEU credit is for live participation for at least 35 minutes. Those certificates get sent out within about 24 hours of the end of the webinar through a third party called Gutenberg Certs. If you have issues, just let me know. The papers are available in our Google Drive. I will send that link in the chat again when I sign off of here. And use that Q&A feature throughout Journal Club for any questions that you might have. And as always, you can email me with any questions or concerns. So let me just stop sharing this. And Nathan is joining us from ATI for our Case in Point series tonight. Nathan, I'll let you go ahead and introduce yourself as far as your history as a resident with ATI and where you reside right now, what you're doing, and then we'll let you go ahead and screen share and jump in with your case in point to start tonight.
Sounds good. So I'm Nathan Andrews. I'm a physical therapist down here in Charleston, South Carolina. I was a recent graduate of the ATI Sports Physical Therapy residency last year and working on studying for my SCS. I sit for that on March 5th. So I can go ahead and
Yeah, let
try to
me.
pull up my
You should be able to share. I have it set so multiple.
perfect. Yep.
Perfect.
So everybody able to see that?
I think you're loading here.
There you
Yep.
go. Yep.
Okay, perfect. So yeah, I'll be presenting on shoulder instability case series that I was able to kind of work on throughout the residency. I worked with Charleston Southern University, so Division I athletes, various sports. We'll kind of talk about that. So I was able to work with 6 specific shoulder labral tear patients. All of these patients underwent surgery of various types. So 2 Bancarts, 2 reverse Bancarts, 1 Bankart and slap, and then 1 Bankart, reverse Bankart and slap, which was actually a revision of a prior surgery. Out of those athletes, 3 football players, 1 baseball, 1 softball, and then 1 track and field athlete. So just to kind of break down rehabilitation with this, surgery. You can break it down into 4 phases. The first phase being that protection phase, going from week 0 to week 6. Intermediate phase, week 6 to week 12. Advanced phase, week 12 to 18. And then the return to sport phase, which is week 16 to 28. There is some variability depending on the repair type. Posterior Bancarts typically are a little bit slower in that progression. So now we can kind of break down the key phases there. So in that protective phase, week 0 to 6, our focus is on patient education, kind of education on wearing the sling, being protective of that shoulder, trying not to do any damage to that recently repaired labrum. We're gradually working on passive range of motion initially, and then progressing into some active assisted and working on submaximal isometrics for both pain modulation, muscle activation, kind of working on building back that neuromuscular control for them as well. From that point, at week 6, we can start the intermediate phase where we progress that active assisted to active range of motion. Later on in that phase, you're allowed to start capsular stretching, depending on the repair type. That would determine what sort of side of the capsule you're working on primarily. Neuromuscular control, and that's going to be a big point in what I try to hit home with here, is that with the neuromuscular control when working with these athletes, the focus doesn't always have to be just on the shoulder. As we talked about earlier, you're seeing these patients for 24 plus weeks. And if you're just doing passive range of motion for the first 6 and then active assisted motion for the next 6, they're going to get really bored really fast and probably not be too happy with how you're doing. So taking into account that these are, in this case particularly, they're high level athletes, and there's a lot more that goes into that than just shoulder range of motion and building up that strength. There's multi-planar movements at essentially all joints in the body. So taking this time to work on sports specific things that don't involve the shoulder just yet. So when I think of this in particular, I think of baseball pitchers. That's what one of the athletes was. And there's a lot that goes into pitching mechanics. So, you need to be able to live in single leg stance to pitch from the stretch. You need to have good hip adductor and hamstring mobility to be able to stride 90% of your height so that you're decreasing the risk of this, happening again in the future as far as shoulder injuries go. And that applies to all sports. So, volleyball, wrestling, whatever it may be, there are things that you can work on outside of the shoulder in this time frame that can not only set them up for better success, but also, make rehab a little bit more fun for these young kids. Then I also talk about periscapular and rotator cuff strengthening kind of initiating at this phase. So gradually starting to build up that shoulder stability. As we move on to the advanced phase, we can start more progressive strengthening, the throwers 10, upper extremity weight bearing, gradually building back that patient's endurance, especially for the sports that require them to have higher level of endurance. So even the track and field athlete in particular, she was a thrower, but she also participated in some of the running events. So being able to maintain cardiovascular and muscular endurance during that's important. Introducing some upper extremity plyometrics. So for a lot of these athletes, starting with a supine medicine ball toss, gradually building up to plyometric push-ups and even plyometric push-ups off of a box where you're increasing the load to the shoulders. From there, during this phase, one of the most important things that we kind of get into is the return to sport testing. So looking at isometric and isokinetic testing of the shoulder, as we know that 66% ER to IR ratio is crucial for injury reduction with return to sport. Additionally, looking at the closed kinetic chain upper extremity stability test and Y balance are good assessments of whether that athlete's ready to return. Also, it's important to consider sports-specific things. So if your athlete's unable to get into the position that they need to throw or to spike or to shoot a basketball, whatever it may be, they need to be pain-free with at least the motion before we can kind of move on to the next phase. And then lastly, that return to sport phase. So again, going through that progressive plyometrics, continued strengthening and neuromuscular control. So now that the shoulder is, healthy at this point and everything's structurally healed and safe to load a little bit more, we can get into more explosive full body movements. And then overhead sport specifics and throwing and hitting programs as needed. I wanted to talk about a few of the exercises that I listed below too. So doing like prone ball drops at 90-90 and in horizontal abduction just to continue to load periscapular and rotator cuff. And then making sure that we get this patient's range of motion back to within norm. So we want within 5 degrees of the uninvolved as far as the total arc of motion. And then I think breaking down return to sport and what I mean by that is also important. So return to participation is kind of getting back on the field, working on sport-specific drills in a closed environment where there's a decreased risk of injury occurring. From there, we go to return to sport, where we kind of make that environment a little bit more hectic, add some external forces to it that, challenge the athlete more and challenge that shoulder a little bit more. In this phase, you also return to playing, but it's probably not at the prior level of play. And then finally return to performance where we're getting up to that prior level of play or greater. Um, in order to return to performance, that includes that we must complete a throwing or hitting program and demonstrate tolerance to contact collision aspects of sport in those uncontrolled environments that we introduced in the return to sport phase. So for these 6 athletes I looked at, return to sport rate, we got 5 out of 6 of them return to sport. The only one who was unable to return to sport was a graduate student who had already earned his master's degree and just elected to kind of move on to the next phase of his life. Penn scores, as you can see, look at shoulder function and disability, initially started at 36, and at the time of discharge, the average was a 90.1. So biggest takeaways from this case series, surgical labral repair resulted in an 83% return sport rate in the sample. And the thing I kind of want clinicians to take away is, once a patient has this surgery, we have 4+ months of physical therapy ahead of them. So not only should we utilize that time to treat the shoulder, but also address global deficits that may have led to the injury to begin with. So again, that ER to IR ratio, total arc of motion in the shoulder, neuromuscular control, not only in rotator cuff and periscapular muscles, but globally, whether it's, again, balance, hip strength, all of those things play a factor in the stress placed on the shoulder, especially in these athletes. And then specific mechanics of sports. So throwers, volleyball, all of the upper extremity athletes. I think that's everything. You guys have any questions for me?
Nathan, I have a question that you did return to sport testing. I'm curious about the isokinetic testing you did, specifically what you did and what were the parameters that you
Yes.
used.
Okay. So yeah, in this specific sample, it was only isometric testing, but in prior athletes that I've worked with when I was still a student, I was up in Pittsburgh at the UPMC Rooney Sports Complex, and they have a biodex there. So we were able to look at isokinetic testing. Specifically, they looked at it in overhead throwing athletes. And they would look at it at different degrees per second, so varying degrees per second to ensure good force production. So I can't relate that back to this group in particular, but I think that that's probably a more specific approach to return to sport with those overhead throwers.
Okay. I see that the general has joined us. This is a good question that I
This
want
guy.
to ask
Do
the
you think that
general.
hey, you think Davies knows about isokinetics?
Well, I don't
What are you
think.
gonna what are you gonna ask him about isokinetics? What would he know that you don't know, Phil?
He literally wrote the book.
He did write
That's
the book.
true.
Literally.
That's true.
The
So,
grandfather of isokinetics with us tonight.
so
Thank you, George.
welcome, George.
Thank
Thanks,
you.
General.
I
Thank you for
it,
the
it re
kind
really
invitation.
is a serious question that we're toying with right now is to figure out, are we doing return to throwing at scapular plane? Are we doing it at 90? Are we doing it at standing at 90? Are we doing concentric, eccentric, concentric? What are we doing? What do you recommend, George?
All of the above.
Of
No,
course.
Yes.
obviously, I think one of the things, if you look at the throwing motion, obviously you have to do it at the 90-90, or depending if or an overhead throw or whatever, I'd still do it at 90-90 for stabilization. Secondly, I would also go back as far as the range of motion permits, because your overhead thrower has a slot that they need to get back to. So limiting them at 90 degrees doesn't make sense to me. So if they have the GERD phenomenon, the increased external rotation, decreased internal rotation, that's where I would set the range of motion stops. Again, people have different philosophies on that. I would do a velocity spectrum testing. And again, if there's any symptoms, I would start faster speeds to slower speeds. Most patients, however, I'll go the other way, 60, 180, 300. Once they go above 300 degrees per second in an isolated movement pattern like that, I find there's too much free limb acceleration. You can window the data and get the information in the center of the range of motion, but I still think there's too much acceleration, deceleration with a start and a stop. So I don't think it's always valid. So I don't go much past 300 degrees per second. For the internal rotation, I think again, we can't really replicate, as we all know, throwing movement 7,200 degrees per second. So we're testing at 300 degrees per second. So it's not really ecologically valid, but it's probably the best reliable thing we have to do dynamic muscle testing of the shoulder at the present time. So doing it concentric, and then I would do eccentric. Because again, when you go back into the cocking position or back into the slot, it's your internal rotators that are eccentrically decelerating the cocking phase. And then obviously in the follow through, it's the eccentrics of the posterior shoulder that's the deceleration phase. So I think doing con and eccentric both ways are appropriate.
George, can you explain, I think you said something really important that I think kind of probably got blown by. You mentioned doing faster speeds first, slower speeds second, or faster velocities first, slower second. Why do you do that?
I typically will do that for regardless of the joint, whether it's a knee. A lot of your patellofemoral patients, that would be a really good example. If they do slower speeds, you get increases in compressive forces, increases pain. The faster you go based on Bernoulli's principle, the faster the fluid over a surface, the less the compressive forces, i.e. it usually translates to less compression and i.e. less pain. So with a shoulder, if somebody's still a little bit symptomatic with something, but I still think it's valid to test them, then I would start faster speeds to medium speeds. And I might be contraindicated on that day to not test at the slowest speed. But the other thing, and I think somebody made the point, I don't know if Nathan made it or not, but we always look at unilateral ratios. And what's interesting is if you look at all the ways to interpret the isokinetics, obviously, limb symmetry, so you do bilateral comparisons. We do unilateral ratios. And what's really interesting, every joint in the body, including spine, hips, knees, ankles, elbows, wrists, forearm, when you look at unilateral ratios at different velocities, the unilateral ratios change. Interestingly, for IR, ER of the shoulder, regardless of the velocity, the external rotators are typically about 2/3 of the internal rotators. So, and that's whether it's 60, 180, 300. And Todd Ellenbecker and I have published that 25 years ago. So, and that's still pretty consistent. So that's something else we look at. But furthermore, we have to look at allometric scaling. And then the other thing that's really important, obviously, with a fast velocity movement like that, is looking at things such as the rate of force development. Then toward the end of the range of motion, I also look at what's called force decay rate. They're eccentrically decelerating, they're slowing down, but do they have a normal convex curvature on the torque curves? Because if they don't, then that's going to show some inhibition occurring at that point in the range of motion. So there's a lot of ways that Nathan mentioned doing the isokinetics. As I said, it's not ecologically valid. It doesn't really replicate the speeds of functional testing, but it's probably the best we have right now for dynamic muscle testing in any joint, frankly.
George, what is I don't remember the name of it. The device you had it was isokinetic, but it can do almost like all three dimensions.
Yeah, there's another
Can you
device
tell us
that's
about that? Yeah.
available. Yeah, there's another device that's available. They really, frankly, have not been at CSM yet. They should be soon, I hope. But it's called Proteus, and Proteus is a 3-dimensional testing device. So in other words, you can start in this position And we can kind of fabricate three-dimensional movement on a Cybex, but it's more difficult. I mean, in the old Bible and isokinetics book, I actually have pictures demonstrating functional testing of the shoulder doing that movement pattern. But you have to do a Rube Goldberg, and the stabilization is not always that good. Nevertheless, there's a new device called the Proteus, and as I said, it has been shown to be by HSS. It has been shown to be reliable and valid. And the purpose of it is, again, it's only concentric though. It does not include, but every movement we do anyhow, at the end of the range of motion, we're eccentrically decelerating. So it doesn't matter. But nevertheless, it's mostly concentric. And the beauty of it is you can do motions in all different patterns. And it provides good objective documentation used commonly in performance enhancement and in fitness training. Has not made a real headway yet into rehabilitation, but I think there's a lot of potential there. So that's the three-dimensional testing that I think is on the horizon for doing three-dimension muscle performance testing with objective documentation.
All right. Thanks, George. Hang tight, George. I think we probably still have more for you, but we have another special guest. I was going to ask you some questions about Dr. Provencher, George, because I know you know him. You've written a book with him, but we actually have someone on right now. I don't know if you can see Mr. Rosenthal, who used to work with Dr. Provencher. Mike, can you tell everybody where you worked with Doc, what you do now, and just give us a little history about you and him working together?
Sure, I'd be glad to. Thanks for
And thank you for joining, by the way.
It was very timely. Thanks for the invitation. So yes, I had the pleasure of really getting to work with Matt when both Matt and I were quite a bit younger. Matt has maintained his hair. I have not. But we started working together, really in the mid 2000s when I came out of the West Point sports medicine PT residency and got assigned to the special warfare community out in Coronado. And at that time, they didn't have a consistent connection with a Navy orthopedic surgeon. As crazy as that sounds, you've got some of the military's elite personnel that don't have a consistent connection with an orthopedic surgeon. And in my youthful enthusiasm, I picked up the phone a couple times and I found this guy by the name of Provencher, and he said, "Sure. When do you want me to come over and have clinic?" And I thought, wow, this is working out much better than I thought. I have to send people over to you. And it helps when your clinic is like 25 yards from the ocean and he can go stand out on the beach every once in a while. But anyhow, Matt has been a pioneer in kind of shaping, developing, and forming the medical team that has grown from really a bare bones medical team providing musculoskeletal care to some of the Navy special warfare community to really, he led that charge for probably 10 years before he retired, maybe even longer than that. And has just really been a great collaborator with the physical therapists as well as the other healthcare providers, from athletic trainers to strength and conditioning coaches. He continues to demonstrate that in the many roles he's had since he left the Navy. And as many of you likely know, he went from the Navy out to Boston, and he wasn't in Boston very long before he found significant success in taking care of some football team out there. I can't remember the name. They've won a few Super Bowls, I guess.
Double, yeah.
Much to my chagrin.
Mike, tell us about so some of us know Matt. Probably my guess is a majority of people on the Journal Club tonight don't know him, and maybe hopefully they've at least heard of him. Those of us that know him, I'm still really hoping, we got like another 30 minutes he can pop on for just like a couple minutes, and definitely because he's so late we're gonna have to get him on again at another time. But I was really, we have some of our favorites, so many of our favorites that come on the Journal Club with us that are really great surgeons and just unbelievable, not only great surgeons, but unbelievable people. But he's specifically one that I think of that, when you talk to him, you could just meet this guy, but you talk to him for 10 minutes and you could swear to God you've known him forever and he's like been your best friend for years. And what I want to know from you is he really that way all the time? Because you've seen him, probably when he's in a good mood, good days, bad days. Is he like that all the time? And what is it that he does that makes him special with patients that he sees?
Yeah, I think you kind of nailed it, Rob, and that it seems like a lot of the orthopedists that you associate with being really the leaders in the field, that's kind of their mode of operating, right? They seem to have that similar ability to connect really quick and really well with both the patient's family members, as well as other healthcare providers across the spectrum, not just their orthopedic surgeon colleagues or that sort of thing. And Matt really is that. He is probably one of the most genuine, positive individuals I've ever been around, regardless whether it's healthcare or any other setting. He is remarkably energetic. I don't know if the guy sleeps. If he does, I've never seen him with his eyes closed. So maybe he can sleep with his eyes open. I don't know. But he really does connect extremely well. And I think, as most people probably on this call realize, I think that's one of the maybe one of the unique things from a sports medicine providing care to athletes, that there's no ability to not have that. If you can't make that connection well with your athletes, your success is going to be greatly limited, no matter how good of a surgeon or how good of a therapist you are.
And I think that and that really helps you. To me, that helps you out too, Mike, when you're working with him or you're seeing his patients. It's a huge benefit to you that they like him, they want to do well for him. He sends them to you, so therefore they want to do well for you. It's just a great relationship that works that way if they really like him. I mean, it's totally different if the patient really doesn't like their therapist, or they think that their surgeon doesn't really care about them that much. They feel put off when they're around them or something like that. It's really different when the patient actually feels like the doctor cares about them and wants them to do well and feels like they're their friend.
Yeah, and he did a great job, does a great job of that with all the patients, whether he's seeing them for something that is not a surgical condition, or he's seeing them for a very complex injury that's going to result in maybe more than one surgery. It's not a criterion-based approach for Matt as far as connecting with those patients. He's exceptionally good at that, and just genuinely enjoys serving the patients that come to see him. So,
Mike, I don't know how deep you could feel like you can go into this. One of the articles that we were going to look at today, and I know he's been doing this for a long time, because I remember him using the distal tibial allograft for patients with instability. I remember, like 15 years ago or so, when we had a meeting at San Diego. One of the first times we had him talk when we were in San Diego, and that's been a long time ago. He was even talking about doing it then. I think he was just starting doing it back then. But have you seen patients that he used that on? Was he using that while you were working with him?
he was starting to do some of that when I was working with him in the 2015, 2016 timeframe. And I believe he really kind of took a lot of that, or maybe got kind of started down that path, certainly through his fellowship training with Dr. Cole in Chicago.
Was Dr. Cole doing that procedure before Matt, or did they start together, or?
I think he and Dr. Cole, together with some of their fellows they had at the time, continued to develop it.
Mhm.
Haven't stayed real close in contact to know who's doing more of it at this stage, but Matt continued to develop that and kind of fine tune aspects of that for a number of years. The patients that I saw that did it, or that had that procedure, did remarkably well.
Yeah, according to the studies, it looks like it works really pretty good. I mean, the curve, I mean, as long as you get sounds like as long as you get the fit right, the curvature is really nice, works well, and is a good procedure. No one here that I know of uses that, so I certainly haven't seen that. George, have you seen any of those?
No, one other thing I'd like to just chime in. I'd like to say also kudos to Mike. He worked with Dr. Provencher, but I also had the privilege to go out and spend time with Mike, both at Coronado with the SEALs and then out in Hawaii when he was stationed out there with the SEALs. And I had the privilege of working with Mike in the clinic and learning from him about some of the things that he and Dr. Provencher have done together. And then again, to show you the camaraderie and the team approach, we basically have Dr. Bruce Ryder, who was the editor of AJSM for many, many years. Matt Provencher and I have actually published a book together as well. So Dr. Provencher has always been very, very cooperative and very supportive of physical therapy. And as I said, Mike invited me to a SOMOS meeting, which is, for most don't know what that is, it's the Society of Military Orthopedic Surgeons. So again, I'm a former Marine, so I've had the privilege to be an affiliate member of SOMOS for many, many years. So Mike invited me there, and I've had the privilege to be a speaker at some of their meetings over the years. But again, kudos to Mike for everything that he has taught a lot of us about some of the interactions, but also some of the things that he has contributed over the years as well.
Mike,
DTAs, the distal tibial allografts, I've only seen a few of those, so I don't have enough experience with a high volume. So, I've seen the more conventional, either the Bankarts or the Bankart and the variations of that, the ladder J's. I've seen more ladder J's than I have DTAs. So,
yeah, I
again, so I can't really talk to the volume of that.
Mike, while you were there, obviously, that population that you're seeing there are you, Mike? I know you're teaching them now, right? But are you also practicing still?
Yeah, I do still practice.
Okay, so my question,
yeah,
my question is can you elucidate for us the difference between the patient population that you see there and the population you're seeing now in Nebraska, right? It's a little different population, I'm guessing.
It is just a little bit to a lot. So yes, I'm currently an associate professor in the DPT program at the University of Nebraska Medical Center in Omaha. And, my current clinical work is broad spectrum outpatient orthopedics. I see more total joints than I do athletic surgery return to sport patients. But in that military environment, especially in the special warfare community with the Navy SEALs, it was more of usually needing to use the reins to slow them down, while touching on some of the things that Nathan mentioned. You had to be very purposeful in trying to make sure you were giving them a lot of other things to keep them challenged or engaged. Otherwise, they were going to go figure out ways to challenge and engage themselves, and put some things perhaps at risk. But it's a population that telling them no usually doesn't go over well. So finding better strategies of.
So tell us, since you mentioned that, tell us some of your strategies that you used to use to try to slow them down. I mean, can you just say, put the job over their head, or, the colonel, Can you throw them under the bus, or how do you handle that?
That doesn't go well either.
Yeah.
No, it's really trying to partner with them, kind of shared decision making to a large degree, and also letting them know there are some negative consequences if you take it too far outside of the limits we're giving you. You're risking some significant consequences, and they are smart individuals. I mean, they've got to be very smart to be able to do what they do. So they're open to the guidance provided by the surgeon and the therapist and the athletic trainer, but they want to push it as hard as they can. I never had a single one of them tell me, doc, I'm a slow healer. They're always telling you, I'm a fast healer. I know Dr. Provencher told me it's going to be 6 months, but I'm a fast healer, Mike. I can get back in 4. So I was usually trying to navigate that with the service members and use the objective tests and measures that we hear over and over to prove to them they're not as ready as they think they are. So things like that. But
it always makes me it really pisses me off when you're trying to slow them down because you're at least trying to somewhat follow the protocol, and they disobey pretty much everything you say and do way more than what they're supposed to be doing at that time, but then they don't have problems.
Yes.
That's like the worst. They do fine, even though they're not supposed to be doing what they're supposed to be doing.
Right.
Good. One of the ways to navigate that is, as Mike just mentioned, is to try to have some objective parameters for them to meet. But I want to piggyback on what Nathan had said with some of his testing for his return to sport discharge. In IJSPT, there are a couple of articles that we've published with Riemann, Kevin Wilk, and myself, and then another article with Riemann and myself. But the point I'm leading up to is because Nathan had some overhead throwers and he had some closed chain individuals, i.e. football players. We stratify them. So to me, you don't use the same testing for return to criteria back to sport with them. We basically look at overhead throwers, and there's certain tests that we have published in IJSPT that have good reliability. And that's article by Brian Riemann, Kevin Wilk, and myself a couple of years ago in IJSPT. And then Brian Riemann and I have published an article that shows the reliability of testing for closed kinetic chain, in other words, collision contact athletes. And so I think that's something important, Nathan, that maybe in the future going forward, to stratify your patients into those that are, I'm going to say, overhead athletes versus non-overhead athletes, because to me, they're two totally different sets of athletes, and they require two totally different sets of testing for criteria to look at their performance. So just an add-on there, I think, is very important from physical therapists, because I know there's a lot of therapists on the call, and I think that's real important. And again, IJSPT is open access, so they're all readily available. And that's one of the beauties of IJSPT is we can get access to that, and it helps all of us as physical therapists do a better job with our patients.
I just put both of those in the chat for everyone.
Good, thank you.
No,
And
thanks.
since we have Mike on and we have the general on, and I realize, we're all anxiously waiting, hoping Dr. Provencher shows up. But if there's any questions from the audience on anything, I think this whole crew is very open to discussion points. I think, when we invite our guests, we ask them to provide articles that they'd like to discuss, or if they want, we'll pick articles for them. So this is a good example of, I think, 2 articles that we were very heavily reliant on chatting with Dr. Provencher about these articles he picked. But we have great experts on the panel who are very willing to talk about just shoulder instability rehab as a whole. If there's questions, burning questions, more thoughts on isokinetics from the man himself. Someone asked where they could get your book, George, and Mike Voigt said it's in the
eBay. Smithsonian or eBay.
Yeah. I don't even know. That was the first edition of that was actually published 45 years ago. So talk about a classic. I don't even know if the remnants of that with the yellow pages are even available anymore.
Wasn't that
So,
Isaac Bible, George, done with Moses? Didn't you co-author with Moses?
we have talked about trying to do an updated thing because it seems like there for a while over the last decade or so, isokinetics sort of fell out of favor. All I kept hearing, it's not functional, it's not functional. Well, of course it's not functional. Nobody ever said it was. But what it does do is gives you objective dynamic muscle performance testing, probably better than anything else we have right now. But nevertheless, that's what
Correct.
I've heard. However, recently there's been an upsurge in that. Ashley, you may want to put the most recent article also that Kevin Wilk and a couple of others of us, the resurgence and the need for isokinetic testing that was just published a year ago. And there's an entire table in there with about 30 different reasons why we probably should be using it if it's available. Obviously, the limitation is the cost, the footprint, the size of it, and all that. But nevertheless, we all do our handheld dynamometry and those types of things. So it's at least a way to put an objective number on it, which I think is important because, again, many of the people on here are also faculty members. 4 of the 5 are faculty, and we've all taught manual muscle testing. 5 of the 5 of us on here are faculty members. But what's really interesting, we've all done manual muscle testing. I mean, I've taught it for over 50 years. I think I'm pretty good at it, but it's still very subjective. It's predicated on your strength and the patient's strength. So again, if we can even use something like a handheld dynamometer that provides an objective number, I think that's a more valuable approach. So back to the overhead thrower that Nathan talked about, if I didn't have isokinetics, and in some places I don't, where I have practiced, I have used the handheld dynamometer. But again, one other thing that most people don't do, I would do multiple angle isometric testing. Most people test in one position. But again, when we think of them going back into their slot, I would test them back there and then in mid-range and then in the deceleration movement and test both the flexors and the extensors or the internal external rotators. So I think doing multiple angle handheld dynamometry testing at least gives us a better indication of the muscle performance throughout the range of motion. And there you will see different unilateral ratios as well as allometric scaling.
There's
So
a
just a
question.
few other concepts with that testing. But again, bottom line, closed kinetic chain testing for a lot of your collision contact athletes, open kinetic chain testing, which are totally different for the overhead athletes. And those 2 articles that Ashley just put in the chat, I think are very valuable because they show the reliability. They give normative data in there with about 50 individuals and all. So it gives you at least a starting point for those who need some information, which test to use. Here's some at least starting data to use for criteria for return to sport testing.
So a couple of questions in the chat. We'll open it up to anyone who wants to answer. But Diego Rojas asked, would the rehab or retest change for non-surgical instability like your Ambry patients or patients with EDS?
Yeah, most of your EDS or your Ambry patients, obviously the problem with them is obviously instability issues, but that's a multi-directional problem versus what Nathan talked about was primarily a unidirectional type of a problem when you do a bank heart or if you do a bank heart and a ladder J or a bank heart and other procedures. But your MDIs or your EDSs are all multi-directional. So again, with those individuals, I think it's even more of a challenge. I mean, the old school way was to do the old, Dr. Neer's capsular shift procedure, because when you do a capsular shift, you pull the anterior part of the capsule, but as you do that, you get the inferior and you tighten the posterior as well. So again, if it's really an unstable MDI or EDS, then if it needs stabilization, then again, you need to work every direction. So, but they're problematic patients. No, there's no question. The big difference is understanding that it's multi-directional versus what Nathan presented was mostly unidirectional.
All right, I'm gonna throw this to George or Mike Voigt, who's my human library, but our friend Adam Rosowski that's on all of these is asking for
Shout out.
yeah,
Adam.
shout out Adam. Any of our best resources for standardization or position for dynamometry testing?
I'm going to open it up to George first. I think it's tried and true. The Bible that George wrote, we were talking about the isokinetic compendium that he said we do. And George, we do need to bring that back. You need to bring updates to it. I mean, it's kind of the gold standard that everybody's used. I think everybody on this panel has used it at one point in our careers and memorized through it. So for me, that would be it still is. I have it on my shelf. It's the starting point. So I know, George, you wouldn't say it to yourself because you'd hold it back a little bit with humility. But I think that's the in my mind the gold standard. I'll throw it to you, George, and see what you say. But that's what I'd go to. You're the expert.
Well, I think we already addressed that.
Yeah.
I mentioned that I would do. Some people say you test only in a scapular plane. I don't agree with that because that's not where you're throwing. You're throwing back in the cocking position. We're getting back into the thrower slot position. So the key though is the stabilization of the trunk and all that. If you want to do the isolated testing of the shoulder. But again, looking at the GERD concept, you have the increased external rotation and the decreased internal. So put your range of motion stops there. And again, do the velocity spectrum testing and look at the unilateral ratios. But again, they have to be stabilized at the 90-90 position, so to speak, for the core and the trunk. And then for the baseball pitcher, they'll be going way back there, and then they're going to have the decreased internal. And that's your typical GERD phenomenon that we're all familiar with, that your throwers have the increased external rotation and the decreased internal rotation. But I would still stabilize. Now, if we can get the three-dimensional testing, i.e. the Proteus, that allows you to do more three-dimensional testing. But there, again, back in the book 45 years ago, we had pictures of people standing using a Cybex and doing a three-dimensional throwing from back in the slot position and all the way through the follow-through, almost touching the ground. So we were able to do that using a longer lever arm for the Cybex or Biodex or Humac or whatever they're using. So we have done that as well. But there's so much variability there with a longer lever arm like that, with the entire core involved, with the lower extremity rotational components, the hip rotation. I mean, I don't think it's as accurate reliability testing for that. But if you want to really look at the shoulder, again, I would do the stabilization of the trunk, and then I would not limit it at 90 because that's not what that's not the thrower's range of motion. That's what I would say. That's what I still do with them.
George, I'm going to reiterate what you said just so another person says it there, but you just hit the nail right on the head that in order to use those ratios or to use for using objective data, which that's what you and I have talked about, all of us on this panel have talked about, we use objective information to help us with our mind to come up with the next best steps that we do. And in my opinion, the mistake a lot of people make is they don't stabilize. And as you were saying, even moving towards that three-dimensional position, or three-dimensional testing, there's so many variables that come into play. The data is somewhat useless. I think you start in isolation with stabilization, and you have to earn the right to move up to that three-dimensional pattern. With Proteus, I know you do it with throwers. I work with professional golf. It's the same thing in the sense that we start in isolation, we test in isolation, start in isolation with stabilization, and then the athlete earns the right to move up into that three-dimensional position.
Once they're ready, yeah.
George, when they're ready, right.
George, is it fair to compare a limb symmetry index in a thrower in their slot with GERD on the throwing side versus the non-throwing side? I don't think that's a fair comparison, though.
If you recall what I just mentioned, if you don't have isokinetics, then I would do handheld dynamometry. But remember, I mentioned you don't do it in one position in a range of motion. You do multiple angle testing. So back to your question, if you're going to do a limb symmetry, there's no way when the non-throwing arm is at 90 and your throwing arm is at 130 degrees to do a limb symmetry there. However, when that arm is at 90, if you look at the torque curve and look at the range of motion, you look at where the throwing arm is at 90 degrees in the range of motion, you look at where the non-involved arm started at 90 degrees, that in fact, I think would be angle specific unilateral ratios. But you don't just do a generic unilateral ratio for the whole thing, for the reason you just said, Phil, because you're looking at totally different arcs of motion. So,
Yeah.
so that's why I would do, as I say, with handheld dynamometry, do multiple angles, and then you can do the unilateral ratios. Likewise, here, look at the angle specific, because all of your isokinetic devices also have the measurements on the range of motion. So you pick out on the arm that's the throwing arm that has the increased range of motion, you pick out on the torque curve where that 90 is. Then when you start on this side, you pick out where the 90 is on the non-throwing arm. There you compare apples to apples, 90 degrees on the throwing side to 90 degrees on the non-throwing, even though their total arcs of motion are different. At least that's how I would compare the LSI.
George, we have a couple people ask more. If you could go in a little, you talked about it really quickly, I think kind of briefly, about the Bernoulli's principle and how increasing the velocity decreases the fluid pressure and pain. Can you go into more detail for people on that? Or
yeah, there's an engineering concept called Bernoulli's principle. It's all predicated on, and the best example I use it, frankly, is patellofemoral. So again, if somebody has symptoms with patellofemoral, as long as they're not really significant maltrackers or any of that type of thing, and you start doing some open kinetic chain exercises, many times that bothers them. But many times when we look at that, we're doing open kinetic chain exercises with weights, and they're usually slower speeds. So Bernoulli's principle states that when you have a fluid medium moving over a surface, that it decreases the friction and consequently allows less compressive forces. So if we take the patient who has patellofemoral problems and we look at the synovial fluid in the joint, so with those patients, I would always start with faster angular velocities first. Rob, you do that too. And then I would work down toward the slower velocities. And again, if I start and test them at 300, they do well. 180, they do well. And I always do 4 gradient submax to max warm-ups at every speed I test. To me, that's a fail-safe system. They do a 25% warm-up, no pain, a 50% warm-up, no pain, 75% warm, and then all of a sudden that bothers them. Even though my clinical judgment thought they were ready to be tested, nevertheless, I was wrong. So that's where the 4 submaximal to maximal gradient warm-ups to 25, 50, 75, 100% warm-up basically is a fail-safe system in my mind that it prevents me from testing somebody and hurting them. So again, with that patient, I'd start at the faster velocities, then work down maybe 240, then maybe if I'm doing velocity spectrum training, maybe 300, 240, 180, then maybe down to 90. If they start wincing there, then I'm going to avoid that and stay at the faster angular velocities. And in the Bible, we have what we call fast angular velocity, or VSRPs, velocity spectrum rehab protocols. So for people like that, we would stay at the faster velocities and then again, if they don't have the symptoms, then we would do full velocity spectrum training.
I have I remember a good friend of all of ours on the panel here. I won't say who it is, but this person told me they were an expert witness for a legal case one time, and it was a patellofemoral patient, and the therapist was getting sued because they did isokinetic testing on someone who had some patellar chondrosis, and they did low, slow velocities, which like just pissed off the joint and made it, like dramatically worse. And the therapist that we know was, telling me how stupid the therapist was. He was, he said, yeah, the guy should be sued. There's no reason he should have done that slow speed. He should have done fast speed. So it's the same principle you're talking about.
Well, they didn't know Bernoulli's principle, Rob.
There you go.
No, yeah, the therapist didn't know it.
That reinforces the same concept that we just talked about.
Yeah.
I'd just like to note how I like how George tells you, Rob, what you do. Did you
No,
notice
because he
that?
knows. He knows. Yeah.
You do
We
that
all
too,
know.
Rob.
No, well, he knows it all. He knows exactly what I do.
I
George, you
just
probably know what I'm
savant.
gonna George knows what I'm gonna have for dinner, probably.
George knows what pajamas you're about to put on before you go to
Exactly.
bed.
Exactly. Yeah.
That is true.
For those on the
Pretty
call
true.
that don't know it, Rob was a resident fellow from years ago. So we've done a lot of things for many, many years.
Well, here's the deal, guys. I think that despite the fact that our very esteemed guest, who we're very excited to have, is stuck in the operating room, which good for his patient, bad for us, good for his patient, that we still were able to have a fun discussion and learn some things about Bernoulli's
No doubt.
principle and
Yeah.
such. So I think what we're going to do, Dr. Provencher had texted us prior to this to let us know he was running behind, didn't know what was going to happen, very willing to reschedule. So we are going to try to see if we can get him on to actually discuss these articles, maybe between this date and our next journal club. If we can't get that to happen, we'll throw it in there. We'll do an extra journal club somewhere so that those of you who are anxiously awaiting to hear from him can hear it. Super, super appreciative to Mike for jumping on
Oh, no
and to
doubt.
George for jumping on.
Yeah. Thank you
Yeah,
guys very
great
much.
Helping
job.
us
Thank
out.
you.
Nobody wants
You
to
guys
hear
saved the
just
night,
me,
for sure.
Rob, and Phil and Mike talk to each other. Very much appreciate all of you that stayed on. Over 300 of you still hanging out with us despite not having Dr. Provencher on here. So diehards, we appreciate you. You're
Yes,
still
no
going to
doubt.
get your CEU credits for tonight. So be on the lookout for some emails coming out. We do already have commitment from Dr. Cristoforetti to talk about HIP next month in
What a
February.
fun
But
guy he'll be.
Oh, yeah.
those
We
of you
got,
that have followed the Journal Club for a long time have seen him on here with us
Yep.
before. Super fun, great friend, huge friend of therapy.
we've
But
got some other good ones.
yeah,
Ash. We've got Dr.
2026 is
Ma. Yeah.
2026 is going to be an awesome,
Yeah, we
awesome
got Dr.
lineup.
Ma. I think he's from is he from USC? USC, right?
Mm,
Dr.
Yeah,
Ma bin
I
Ma.
think so.
Ben
Yeah.
Ma, yeah,
We got Mike Freehill from Stanford.
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 Yep. We got Mark Stovak, who George knows. George was in we're in Japan or China with Mark, one of them. I know.
The
Olympics.
2008 Beijing Olympics.
Yeah, yep.
Worked
So we have
together.
him in October, and then we have one of our favorites, Rachel Frank, coming back toward the end of the year.
Yay!
So
I didn't know that. That's
yeah,
awesome.
yeah,
That's good.
yeah. We got a good lineup.
Perfect. Yeah. So thank you to everyone for sticking around. Replay will be posted, certificates will get sent out, and be on the lookout for emails about rescheduling Dr. Provencher. Nathan, thanks for joining us. Appreciate you hanging out. And thanks again, Mike and George, for jumping in.
Thank you guys.
Thanks,
Thanks,
guys.
everyone.
Great.
Have a great night.
Thanks for having me.